Hi, my name is Srikanth, and today I'll be addressing eating disorders in a global context, barriers to recovery, and proposed interventions. I'm a rising junior at William Mason High School from Mason, Ohio, and am very passionate about public health and medicine. I compete in extemporaneous speaking and was recently named a national semifinalist. Additionally, my current research involves evaluating the efficacy of certain therapeutics on anorexia nervosa, and I'm a member of a policy translation team that uses advocacy to address EDs across the United States. I'll begin by defining eating disorders, or EDs, and their views. The DSM-5 defines 3 specific EDs and 2 categories of EDs, so the term encompasses a broad range of conditions. EDs are highly stigmatized, with one study reporting that 1/3 of the general population actually blames ED patients for an ED. However, we can't hold patients responsible, as EDs are up to 60% heritable. They're better described by the biopsychosocial model, which suggests that genetic, cognitive, and environmental pressures all contribute to ED development. Given the stigma surrounding these illnesses, it's important to clarify the psychopathology behind each of them. Anorexia nervosa is the rarest of the major EDs, but it's also the most dangerous mental illness. A patient experiences preoccupying cognitions about their body shape, combined with an obsessive fear of weight gain and negative emotions associated with food. To alleviate these anxieties, patients execute risky behaviors that can be compensatory, like overexercising to make up for calories, or restrictive, like cutting out entire food groups. Now, self-starvation results in imbalances of hormones and minerals that can disrupt a patient's menstrual cycle or cause a loss of bone density, osteopenia, or osteoporosis. Starvation-induced organ and brain damage can also be permanent. Given this, AN has the highest mortality rate of any psychiatric disorder, with over 5% of patients passing away within just years of an initial diagnosis. Now, bulimia nervosa, or BN, begins with similar repetitive shape and weight-related cognitions. Patients also exhibit an obsessive fear of weight gain. However, if BN patients overcompensate or restrict, it leads to increased cravings that cause the individual to lose control around food. After an episode of binge eating, BN patients purge to prevent themselves from digesting nutrients. Some complications of BN due to malnutrition are similar to those perpetuated by AN, but forceful vomiting causes tears to the esophagus lining, leading to potentially life-threatening bleeding. Stomach acids damage tooth enamel and can also cause heartburn and increased risk of various cancers. Now, binge eating disorder is the most common ED type, affecting 2.8 million people in the United States alone. The primary difference between BED and BN is that periods of binge eating are not followed by purging, excessive exercise, or fasting. BED patients regularly do not compensate for overeating, and while body image disturbances can occur as a root, they are not required for a diagnosis, unlike BN and AN. The 2 other ED categories defined by the DSM-5 are ARFID, avoidant restrictive food intake disorder, and OSFED, other specified feeding or eating disorder. ARFID is not just picky eating. An individual struggling with ARFID has inability to consume foods due to texture, smell, or visual presentation. Patients are not afraid of weight, and aversions are caused by a fear of allergy or choking. If they fail to maintain appropriate weight, this can cause kids especially to deviate from their growth trajectory. Now, people with OSFED have similar symptoms to other EDs, and there are different diagnoses that can be made within OSFED. A few include atypical anorexia nervosa, which happens when all the criteria are met for AN, except that an individual's weight is within or above the normal range. Bulimia nervosa, or BED, of low frequency occurs when all the criteria for BN or BED are met, except that binge behaviors occur less than once a week or less than 3 months. But in the US alone, every 52 minutes, someone loses their life to an ED, meaning the clock is quite literally ticking when it comes to taking action. But this is not just a domestic problem, it's a global issue as well. Over 700 million people worldwide are affected by an ED, comparable to 2 times the size of the US population. And more than half of teenage girls engage in behaviors that put them at risk for developing an ED, yet the condition affects men, women, and LGBTQ individuals alike. It's critical to observe why progress hasn't been moving forward. So with my research in AN therapeutics and learning about the options available for treatment, I was inspired to investigate the specific global health barriers responsible for impeding progress. What I found was that worldwide influences can be organized into 3 main types of barriers: barriers to individuals receiving treatment, issues with treatment quality, and factors behind original ED development. Now, one study reported that less than 4 in 10 adolescents actually acquire ED treatment, and the reasons for this lie heavily in economic disparities. Firstly, ED treatment can range from an occasional therapist visit to an inpatient hospital stay. For intensive treatment, this costs over $1,200 per day. leaving low-income households unable to invest in life-saving support. Second, a study found that 21% of insurance plans categorically exclude EDs because they're in a gray area between physical and mental health conditions. Both of these issues can be addressed by forming public health plans, which reduce ED expenses for those facing economic hardships, allowing them to access treatment without disrupting their standard of living. Now, for those who can access treatment, quality is often not guaranteed. In Canada, wait times for treatment are up to 420 days, which increases the risk of intensified health complications. Creating appropriate waiting time standards should be introduced as soon as possible, so general cases receive treatment within 4 weeks and urgent cases receive treatment in 1. Second, funding for EDs is less than $1 per affected individual, so it's a highly under-researched category of mental illnesses. Increasing research funding allows clinical trials to be conducted and services to be better staffed. Third, less than 50% of patients receive all the information they need about ED treatment upon diagnosis. So investing into early intervention or school-based programs will help educate patients about their condition and care options. Now, in terms of the biopsychosocial model, global health action can target the social and environmental factors contributing to an ED. Firstly, weight discrimination rates actually increase youth ED risk. In the US, Michigan is the only state with laws against weight discrimination. Outside of the US, no countries except Iceland have enacted laws to prohibit weight discrimination, despite high rates. Now, expanding legislation globally to address weight-related mistreatment among youth and adults will improve equity and decrease ED onset. Second, companies like Instagram, unsurprisingly, have algorithms that promote unhealthy body ideals and amplify content that encourages extreme weight loss. Strictly regulating digital media and misinformation is the best way to combat this issue. Third, because diet pills are readily available to youth, young adult women who use them are 4 to 6 times more likely to be diagnosed with an ED. This is where my work has been, targeting the issue by contacting legislators and bringing attention to a bill that can regulate supplement exposure among youth. Funding and policy are clearly the largest barriers to reducing ED development globally. So, advocating for legislation and improving financial allocation towards EDs can move progress exponentially in the right direction. I would like to thank the team at Striped for their endless support of my research in policy and medicine. I thank the GHLC team at JHU for giving me the wonderful opportunity to present today. And thank you so much for listening to my presentation. These are my literature and research citations in ACS. These are image citations. And if you're interested in learning more, getting involved, or have questions or comments about my presentation, feel free to contact me at the given email. Thank you.